So, hello everybody. Welcome to one more online seminar session from BEGO Implant Systems. We were already missing you. My name is Marcio Garcia dos Santos. I'm part of BEGO Implant Systems education and clinical research team and will be the moderator of today's session. First of all, I hope that you and your family are all in good health. Before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO Implant Systems Marketing Department for the organization of this session. The topic today will be implant surgery and fixed teeth in the same day, total rehabilitation over 4 implants in patients with posterior sector atrophic jaw, and the speaker will be Dr. Vitor Hugo Familiar from Portugal. Dr. Familiar is CEO and Clinical Director at Dr. Vitor Hugo Familiar Dental Medicine, has degree in dentistry from the Faculty of Health Sciences at Fernando Pessoa University in Portugal, has a postgraduate diploma in dental implantology at the University of Santiago de Compostela in Spain, is also university specialist in dental implantology at the same university. He's an international trainer and lecturer on the topic all-on-4 technique and is exclusive clinical practitioner in oral surgery and dental implantology in his clinic. Vitor Hugo, my friend, thanks for accepting the invitation to conduct this session. As always, at the end of the lecture, we will have a question and answer session, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time, and I give the words to Dr. Familiar.
Hello, Marcio.
Hi, Vitor.
Everything okay? The audio is good?
Everything's fine?
Okay. So, shall we start then?
Yes, please.
Okay. So, hello, everybody. First of all, I want to thank your presence here today for this webinar. I hope that all of you are in good health, as well as your families, and that all of you are passing through this difficult phase the best way possible. In second place, I want to thank BEGO BEGO Implant System for the invitation. It's a really honor to be here today and share with you a little bit of my passion of what I do, and let's hope that you enjoy. So today we are talking about this technique, the total rehabilitation over 4 implants, and I will mainly focus about the day where everything happens, the day where we can deliver the teeth to the patient, when we can really transform their lives to the surgery day. Dr. Marcio already introduced me. Just let me say that I'm from Porto, the north of Portugal, which is well known from its magnificent Douro River, the world famous Porto wine, and of course, the best football club, not at the moment, and if you want to search it, it's FC Porto, and this is not a good year for searching for this club. Let's hope that next year you can search for it. But mainly Portugal is well known in the implant dentistry and world known for its development in this technique, the all-on-4. We are based at a small, lovely town by the sea, which is called Aguda. It's very near from Porto, 50 minutes from Porto. And this is my part of my lovely staff that works with me every single day. And this is what we do, a little bit of what we do. As you are going to see through this presentation, I'm not this kind of guy that like to edit photos. I like to work with raw pictures. These are the kind of pictures that I show to my patients when they want to see what kind of transformations we can perform. And let's hope at the end of this webinar, you two are also in good shape to perform this. So the main question when we talk about total rehabilitation in just one day, the main question is this one: is it possible if we go from this situation to this in the same day? Which means going from a poor oral condition like this one, and in the same day we can extract every teeth, we can place the implants, and we can deliver fixed teeth. The answer is yes, we can. We can do it, but in order for that to happen, we need to look at things differently, what I like to call the paradigm shift. We need to look at this treatment, at this kind of treatment, as a whole process that usually involves less costs for the clinic, for the patient, less treatment time, which is a very good advantage, and mainly it's a life-changing experience for the patient. And this one is based on the immediate results that we can achieve. And to tell you about this life-changing experience, this is one of the best examples that I have. This patient is a friend of mine, and for the last few years, she was very unhappy with her situation. She had some bad teeth. She had some advices to go through very complicated, very complex treatments. And one day she came to me and said, I want to fix all my mouth. I want to make a full mouth transformation. And after a few appointments, I tried to make her understand that we have another options. But one day she said to me, look at my Facebook page. And I made this print screen from her gallery. And as we can see, she was unhappy. There wasn't one picture of her smiling. We performed the surgery. And this is a random picture from her gallery Facebook now. And now she's all smiles. And this was truly a life-changing experience for her. In fact, her life gave a big turnaround. She got divorced, she wasn't happy, and now she's very happy. But in order to believe in this kind of treatment, we have always some doubts that people, the patients, or even our colleagues have some doubts about some things, like do you treat or extract the teeth, the number of implants, and of course the remaining doubts about tilted implants. So we are going through each one of these in a simple way, and these are the cases that doesn't leave us many doubts. So when these kind of patients enters my clinic, I don't give them the chance to, if they want, of course, to leave any teeth, because let's face it, these are in what we call the all-on-4 treatment. These are the simple cases that doesn't leave us any doubt. So about the number of implants, in 1905, Professor Brainmark already questioned the tendency of the clinicians to install as many implants as they can. And here we have what I like to call, just for fun, the all you can afford versus the all on 4. Let's face it, no one can say that the treatment on the left is bad performance. It's a very well performed surgery. It's another philosophy. In fact, the final rehabilitation is very well performed with 3 section parts. But the thing that I like to compare most is the spaces between the implants. And let's face it that there are many spaces in this upper jaw, and it's very difficult to clean the spaces between implants. And with this kind of treatment, we could give the patient the same number of teeth, and by consequence, less number of spaces to clean. And in long terms, we all know that this is a crucial thing. And what about tilted implants? What makes everyone so confused sometimes is it possible to place tilted implants? Since 1999, from Matson to Krakmanov to Professor Aparicio, there is a high success rate on the tilted implants. There are some advantages by using this kind of implants when they are angulated, and I like to highlight these 3, which are the better use of available bone, the longer implants in better quality bone, and reduction of cantilever length. As you can see in the diagram on the right, in the same arch, in the same upper jaw with the same space, we could provide a shorter cantilever, and we could provide longer implants. And longer implants, as we all know, provide us better beak around other advantages. And is it safe to tilt implants? So through the years, these are the main questions about the tilted implants. The bone loss. Do you lose bone around the implants? Do they fracture the components as they are inclined? And the higher concentration of stress that could happen in those implants. So we have plenty of studies and plenty of articles that showed that was no significant loss bone between tilted and straight implants, or there wasn't any kind of fracture of components, only a few unscrews from the prosthesis, and the micro movements. In fact, they exist, but they aren't enough to compromise the osseointegration. And we reach the immediate loading. So this is our wild card. This is what we can promise to the patient when we are talking to them about having fixed teeth in the same day. So there are some advantages for the patient and of course for us as professionals. And the less number of surgeries is coming to both of us, the less number of appointments, and all of this based in a high success rate. Of course, there are disadvantages regarding immediate loading. Sometimes, and I put here, it's not possible in every case. As we are going to see through the presentation, even when we can't give our implants the highest torque that we want, sometimes there are ways to go around that and load the implants, the remaining implants and the prosthesis. We are going to see that further. And of course, the learning curve and the experience of the surgeon is a very crucial factor to perform this technique. So we have to have a solid learning curve. It doesn't matter if it's fast or if it's slower, as long as it's solid. Overall, this kind of treatment allows some really good benefits for the patient. As we all know, they gain self-confidence, they have a better quality life, they regain the pleasure of eating. And one of the good things that I've been learning from the last years is that usually they go and they scream at the whole world, the people they know, the family, and they go like, I did this in just one day. And then people start to want that, to be able to have the same thing that a neighbor or a relative has. Regarding immediate loading, we should always aim for the plan A. And the plan A is when things go smoothly. We plan the case, we put for implants, after the implants, we put the multiplus, we put the prosthesis, the provisional one, and after 4 to 6 months, we deliver the final prosthesis with usually a titanium milled bar. Sometimes we have to go to plan B, and plan B, it is what I was talking about. At this case, for instance, the distal implant on the left side of the jaw, it turned out to have only 10 newtons, I guess, only a slightly primary stability, and I wasn't able to load it. I even put a pterygoid here, and as these three were with a big torque, a higher torque, and the patient went home with a soft diet, strictly soft diet, and after I guess about 6 to 9 months, I loaded the implants. And there is a plan B sometimes when we only cannot put the implant because the bone is too soft, it's a really mess, for several aspects that we all know that sometimes happens, but that's not a sign that we can't load and the patient can have fixed teeth in the same day. In this case, usually I have a serious talk with the patient, and normally I say to them, look, if you want to have fixed teeth, you have to go through a diet soft diet, sorry. And in this case, we didn't place the implant, we did a small graft. After 3 to 4 months, we put the implant, he got good primary stability, and now here she is with a final restoration. And in this case, for example, the patient was very happy. This is her with the final restoration already. But in this case, we have to change a little bit our plan, but the goal wasn't changed. And this is the case, the plan C that I talked earlier. So she left the office with fixed teeth. She went through a strictly soft diet. After that, we put the implant, and now she has her final restoration. So, regarding the all-on-4 treatment, the total rehabilitation of 4 implants, we went through the paradigm shift that we know that has to happen. We had the literature on our side. We read it. We know that the implants work. Are we ready to go to give the next step? Which means, do we consider the cases like this? Are we able to perform a case like this? In this case, this patient, she's an hairdresser in Switzerland. She's Portuguese. She came to our office and she wanted to fix her upper jaw. And I gave her this option with several endodontic treatments, probably the provisional acrylic teeth sets, maybe a sinus lift, implants. Basically, it was a multidisciplinary treatment, which was very long. And then she told me, that only comes to Portugal 1 or 2 times a year, and she only comes for 1 week. So we hadn't much time to this kind of dynamic treatment. And she rejected this. So we went through another option. This was a little bit faster, a little bit easier, and involved the extraction of the teeth that she had, the placement of 4 implants, and the acrylic bridge, the provisional prosthesis. And after that, she returns for impressions and do this in the same day, in about 2.5 hours. So we had green light. We went for the surgery. This was conventional, what I like to call a clean surgery. We did the anesthesia procedure, the bone reduction. We are going to talk further. We place the implants. She goes to the recover room, and after about 1 hour, we deliver the provisional teeth. And this was her after the surgery, a little bit swallow. Okay, I couldn't see the teeth in its full way, but right before she returns to Switzerland, she came to the clinic. She were more swallow. Okay, it's normal, and I asked her to send us a picture a few weeks later, and she sent us. And right here, when I received this picture, I could understand that we are going in the good way of the treatment. So 4 months after she returned to the clinic, the tissues were in very good condition. She had a very good hygiene. So we went for the prosthetic protocol. And after 4 months, we deliver the final restoration. And let's start understanding and going through the concept of protocols for doing this that we just see. So in 1998, the Holland 4 came along and revolutionized the world of implant dentistry regarding full arch. And the advantage of this technique is that you maximize the use of all remnant bone that we have, and that allows the immediate function and avoids the regenerative procedures that increase mostly costs and the patient morbidity, which is basically doing this treatment. It's when we put 2 implants vertically in the anterior region, and then we put 2 implants placed in the posterior region. So it's 2, 2. But the distal implants in the maxilla, they are placed tilted anterior to the anterior sinus wall. And in the mandible, they are placed tilted and anterior to the mental foramen. And those implants, so those distal implants, they are placed at an angulation between 30 and 45 degrees. Therefore, we have to use the multiples that are going to that are allows to place our screws to place the most parallel way of fitting the prosthesis. They are gonna make the reverse treatment. This treatment always it's made for using fixed teeth. So it's a full acrylic prosthesis with 10 to 12 teeth. So the concept of All-on 4, it's implants, multiplets, titanium abutments, and the teeth, everything in the same day. And this technique allows longer implants, therefore allows higher beak, allows us to have bicorticalization, and therefore higher primer stability. And of course, as the distal implants are inclined, the cantilever gets shorter, which is the ideal situation for any kind of rehabilitation. So this is a very clever technique, and there's been working for many years, and there is no reason to be afraid of doing it as long as it is well performed. And about this technique, there are some golden rules that of the whole concept of the treatment. There are the golden rules that I like to highlight every time that I speak about it. And of course, it's the limits of the anatomy that we have to respect. And we know that in the maxilla, we have to respect the 10 millimeters high, the 5 millimeters width, and in the mandible, the 8 millimeters high. We mustn't forget to leave always 30 to 34 millimeters, which means 15 millimeters per arch, and that those 15 millimeters have to contemplate the teeth, the acrylic gingiva, the multiplus, and the multiplus abutment. But this, for me, is the biggest rule that we have to respect when we are facing this kind of rehabilitations. I always like to say, don't forget, please look closely, the smile line considerations. Pay special attention to the transition zone and smile line. This will be the difference between a success case or a nightmare. And I say that's a nightmare because when things don't go as planned, this is what happens. These two cases I received in my office, and they were slightly different. In this case, this gentleman has no problem of doing another surgery, because to perform this concept of treatment, there's no other way unless we have to make a new bone reduction, we have to put implants over the transition line and new teeth. So it's in fact is going to do the lower jaw too, the mandible. So this case is done. But what about this case? This lady, she spent her lifetime savings in this treatment, and someone put 4 implants. Okay, I don't know if they call it all on 4 or not, but the treatment was like this, with 4 implants, but there wasn't any kind of bone reduction. As you can see in the prosthesis, there was any multiplus. The screws are attached, the prosthesis is attached directly into the implant. So in this case is a drama, because she doesn't have any kind of money to support the costs of this surgery. So we are going to make her a new prosthesis and maybe give it a little transformation here to in the way to disguise a little bit better. So please don't forget the smile line consideration, don't forget the transition line. And the best tip that I can give to how to learn how to see where the transition line is to ask our patients to make her full their biggest smile, the biggest smile they can. And when we have a dentalist patient like this one, sometimes it's easier. This lady, I just asked her to make the funniest smile that she can, and she went like this. Okay, I see that I have bone that I have to reduce. Even with her prosthesis, the removable prosthesis, wasn't able to hide the gingival, the gummy smile. But after the surgery is performed, we could do that. As you can see, transition line, bone reduction done, and provisional teeth. Another difficult case. This one has her own teeth. So we went through the edentulous, and the edentulous are the easiest one to make a big smile. In this case, she wasn't very happy with her smile, but she had some crowns, some older treatments, and I asked her a big smile, and she went like this. So it was a risky case, but at the end, it turned out pretty good because we paid special attention to that transition zone. And of course, I always like to show this case. This patient had a removable prosthesis, and I asked her to make the biggest smile. I even tell her a joke, and she went like this. And something told me that this wasn't the best that she can do. So I put back the little removable prosthesis because she was much more comfortable with her. And I said to her, give me your best smile now. Make a funny face, close your eyes, do whatever you want, but please show me that gum. Show me where the gum, where your lip can go. And she went like this. And look at the difference. Look at the limits that we have to check good. And now. So if in this case, we went through the surgery with this reference, it would be a nightmare. It would be like the case that I showed with that guy that had the transition zone at site. And overall, at the end, we could make this a simple and beautiful rehabilitation, in my opinion. So as you see, this bone reduction is very, very important. And how do you perform this bone reduction? In somehow, it's very simple. When you pick up a surgical pen, and before anesthesia, you ask the same smile that you had in the first pictures, and the people are going to smile. And with that, you make a line. You trace a line with that surgical pen, and after that, you make the anesthesia procedure, and only after that you mark that spots, you mark that line with a conical drill, for example, as long as you perforate the cortical buccal bone, because when you do the flap, you are going to see those spots that you marked before, and after that you advance for a conventional osteotomy. In this case, I use the biarticulate osteotomy, which I always use in the first step of my bone reduction. Of course, another golden rule for this technique is the high torque that we need to have on the implants. This is a learning curve for sure. You know how to, you first of all, you have to under prepare the bone, and after that you gain sensibility in your hands. You start to understand how your implant works, how your bone works. But as I said, it's a learning curve, but it's very important to have high torques, otherwise we can't provide the immediate function. So now that we've seen the golden rules for this treatment, we are going a little bit deeper in the surgical protocol, and things are going fast. The concepts are there. So in this case, we are going to put this. We are going to transform a thing that it's at first sight is very complicated, like a cockpit of airplane, but when we follow the protocol, when we understand the concept, things are going really good and almost in autopilot. So about the surgical protocol, I'm going to share for me when it starts. And it starts before surgery. The day, which I call the day zero, it's when the patient knows, he tells you that he's going to perform the surgery, and their doubts start to happen. Usually they ask if it's painful, will I swell, will I get bruised? And all my answers usually are, it's a pain-free, usually it's a pain-free procedure, and people usually don't swallow too much or get bruised, but sometimes it happens. Okay, we don't sell, we don't give illusions to the patients. We have to talk to them, and we have to give them a reality check of things. And sometimes I even show them these kind of pictures, and I tell them, okay, most of the times people don't swell, but sometimes they swell. So sometimes this could happen. You can swell, you can have your bruises, you can probably you can deal with a small pain 1 or 2 days, but you have to look at the final result, and sometimes that happens. Another thing that I do always before surgery is to show this to the patient. I have a model where I show them where we are going to put the implants, the kind of prostheses that they will have. I even usually give them a provisional prosthesis that I have here, and I give them to their hands, they can check what it is. I show them pictures also of what do they have in mouth. People usually think that they will have natural teeth, and we don't provide them natural teeth. We provide them a prosthesis. And to understand the surgical protocol, I think the best way is to see a clinical case from the end from the start to the end. And we start planning the case, which is one of the most important things is when you plan the case. We go through the patient health conditions, we collect all the data concerning the health of the patient, we do the panoramic x-ray, we are going to do our CBCT, we go through the impressions, we look at the casts, okay, and we take photographies of the patient. And I usually take photographies with my cell phone. I would like to have time to make a nice photography course. I'm sure that a lot of you that are seeing this have great pictures with a lot of quality. Unfortunately, I didn't have the time yet to do this course, but with the cell phone, to communicate with your lab that what you want to do the case, it's enough. And the patient photographies. This is the protocol that along with my dental technician, I use. I don't use the other protocols there are with 8 pictures, with side pictures. Usually I use these 4 pictures. And guess what? You know what the most important is. After all we said earlier, this is the most important one, because this is where we are going to see the transition line. And in this case, we can see that we aren't going to do a big bone reduction, okay? We are going to do like just a kind of osteotomy to create a good shelf for the implants, but we have to do it. We have to be aware of it. Just let me say one thing, that during this case, I chose a couple of pictures that aren't from this case because they were better ones to show some things that I like to highlight. So when we take our intraoral pictures, look at what I see. I don't look at the teeth. I don't look at the shape of the teeth, where they are going to be. That's my technician dental technician work that is going to perform. I just look at the transition zone. So now we are looking at where we are going to cut our bone, where we are going to reduce to make our osteotomy. And hopefully it should be right over here. As you can see, through the limit of this inferior wall of the sinus. And if everything went good, we can put our implants. So before surgery, I always like to have an appointment with the patient, usually 5 days before the surgery, where they can, where I explain them the medication that they are going to take. They sign all the documents that they have to sign to give their authorization to the surgery, and I even usually provide them a maintenance kit, hygiene maintenance kit, because I like to give them that responsibility. I don't like that they came through after the surgery and I forgot to buy this at the pharmacy. I forgot to buy the water pick or the surgical brush. So I provide this. Regarding the medication, my protocol, what I usually do is to provide antibiotic 3 days prior to the surgery, and then I give the corticosteroid and the anti-inflammatory. So we are getting ready to perform our surgery. We need the material to perform it. We need the implants that we plan, the multiplus, usually the 30 degrees to the posterior, okay, to the tilted one, and usually straight implants, the 0 degrees implants. Sometimes we have to use the 20 degrees also. We need the multiplus abutment, the healing post, and of course the splinting, the multiplus insertion splint, which in the case of the multiplus insertion splint from BEGO, it has this line of these laser marks of 20 and 30 degrees, and these are very useful during the surgeries, because when you are placing your drill to start perforating, to start making your site preparation, you know exactly if you are going through 30 degrees. And the surgery day has reached. I always like to say one thing that's very important. I never perform null-and-force surgery, and as you know, you need 4 implants and 4 multiplus and 4 abutments. I never go to a surgery with only one of each, with only 4.1 by 15 millimeters. I always get everything in double, because during surgery you have one shot, and if you don't have an implant, if your implant falls out, of course you have to have other options. So we start our surgery by marking the vertical dimension of occlusion, and it's very important that you write it down somewhere at the surgical field or any place, because this will be very important for our technician when the capture of the prosthetic when the capture of the prosthesis happens. You go through the anesthesia procedure, usually 8 tubes per arc. I normally use between 6 and 7. It's very important that you can block the infraorbital nerve, and the rest is distribute the tubes for the whole arch. And we start the incision. There are 2 ways of doing the incision. In a dentalist patients, it's very important if you go crestal but slightly palatal. Okay, you always have to preserve the maximum keratinized gingiva possible. So in a dentalist, always be careful to go more palatal than buccal. When partially dentless, you can go through make an horizontal incision just right upper the zenith of the teeth, but trying to preserve the maximum keratinized gingiva possible. After the incision, you go to the full thickness flap. It's very important that you make a very good flap. It has to be full thickness because you have the surgery field. You want to see everything in your surgery field. Sometimes a tip that I can give, what I do basically is to use a gauze with saline water, and I push it here through to the flap, and there are two reasons to use that gauze. It's for first of all, not harming the tissues. As you know, when we are making our flap, it can easily make harm to a tissue, and it keeps also that gauze keeps our tissues moistened, which is very important for the first phase of healing. And in the palatal side, we usually give 1 or 2 simple stitches, just then we can see better and stretch all the palate in the same direction. In this case, we just made a small bone reduction. It wasn't an extreme case, as I call it. I always use first the biarticulate osteum, then I go with my prosthetic drill and create a shelf. And don't forget that this shelf can't be straight, okay? This shelf has to have a little inclination from buccal to palatal, okay? From buccal to palatal. It has to be a little bit tilted, and that's for the hygiene of the prosthesis, the design of the prosthesis. It has a lot of advantages when we do it like that. So after the bone reduction, after the leveling of the shelf plate, we put the multiplex insertion splint, the all-on-4 guide. We make a drill at the middle line, and after that we have all the reference. So let's get into the difficult, the tricky part of the posterior tilted implants. So when I started to perform this kind of surgeries, I always did this procedure, which is we make a drill in the wall of the buccal cortical bone, and we then, with the help of a probe, we can explore where the anterior wall is. Okay, like in this diagram, we pick the probe. After this, we mark the spot, we put it outside, and we see if it's 2, 3, 4 millimeters, and then we mark with a pencil or a sterilized pencil or a surgical pen. We mark the line of the interior wall, and after that we know that we have to enter 3 or 4 millimeters anterior to that area. Nowadays I don't use it anymore, but I always like to give a shot with an X-ray. I like to put my drill, my first drill, the pilot one, and after the pilot one, I see if I'm in good bone, in good condition, and I go forward. After that, you know where you are, you know all the bone, you know where your implant is, you even have the laser mark that shows you that you are entering 30 degrees. So you go through a conventional procedure, a drill procedure. In this case, we put an RSX 4.1 by 15. So as I talked earlier, don't forget when to prepare the bone. In this case, to put a 15 millimeters implant by BEGO protocol, I go through the pilot drill, then I go to the 2.5 until the measurement of 15 millimeters. Then I used the 375 for those of you who are familiarized with the BEGO kit, instrumental kit. I used the 3.75 drill, but with that I don't reach the 15 millimeters. I start to give it a few millimeters that my implant could work itself. Okay, and then with the 4.1 I go like, in this case I go like 10 12 millimeters. The remnant millimeters, it's the implant that is working, and that's when we are achieving a very good torque. After the posterior implants are placed, I always start with the posterior ones. After the posterior implants are placed, you start to put the vertical, and these are the conventional ones, like everyone knows how to perform it. It's the drill, the straight ones, and don't forget to under prepare also in this area. Okay, I always like to go with higher torques for the immediate loading. So after the distal implants are placed, we put the anterior ones, and after that, only after that, we put the multiplus. Okay, usually multiplus are the 30 degrees. Okay, the anterior, I use straight implants, and sometimes when they have a little inclination, because we have to avoid sometimes the collapse of the buccal area, we have to go more palatal, or sometimes we have to give them a biggest inclination, and therefore sometimes we have to use the 20. But the protocol, the ideal approach is 30 degrees on the distal and straight multiplus abutment on the anterior ones. And as I said before, the importance of multiplus, so they are giving you the passive fitting of the prosthesis, and obvious they will reduce the cantilever. They have other advantages, the easy access to prosthetic screws. They provide less loosening of screws too. So we have our implants, we have our multiplus. The adrenaline of the surgery is going a little bit down. Things went well. Everyone has every implant had big torques, higher torques. So now we place these abutments, and this is the ideal approach. It's when you can and you should always have this space, this good gingiva, and you can, with for instance a round scope, a round mounted drill scope, or even with a surgical scissor, you can make a cross and go over these abutments. This will be great because after the healing process, the keratinized gingiva is there, and the aspect is incredible. So we perform the suture. In this case, I didn't went with this ideal approach. I just went with this one. But after the 4 months, and that's only when I removed the prosthesis, I took from 3 to 4 months, I performed the surgery. I give a good torque to the screws, and I only remove the prosthesis with 4 months. And usually, this is what the gingiva appears, a very good health around the neck of the abutments. Okay, and this patient was a clean one. It has a good hygiene, so I was very satisfied with that aspect. After that, it starts the magic of our dental technicians. As you know, they are a big an important part of our work, and this is how my provisional prosthesis gets in the clinic. My dental technician always brings me the prosthesis like this. We discussed already where we should perform our bone reduction. He works from there. After that, he marks the spots that he is going to open. And this protocol we developed through the years. And it's way more cleaner than the old one or the conventional one that I'm going to talk a little bit further. So with the prosthesis opener, okay, he used usually a self-cured resin just to make sure that the abutments doesn't move and the prosthesis is captured. As you can see here, these abutments, they can't move 1 millimeter. So they are all attached. And after this is going to our lab and is going to reshape the prosthesis, is going to give the prosthesis a good polishment. This is a useful tip that I always like to share because it allows me to don't have any kind of big problems with fractures or sometimes the patients use the provisional prosthesis too much time, usually concerning the money they don't, the cost that they don't have yet to perform the final treatment. So we use this, I guess, if I remember, it's a 0.9 millimeters bar. I guess it's titanium or a steel bar. And this is the aspect of the prosthesis after. So this is the final aspect of our surgery. Okay, well distributed implants, low reduced cantilever, short cantilever, almost non-cantilever. Okay, we can have one teeth cantilever maximum usually. The implants are well distributed. Okay, almost like the planning that we did. In fact, this one was a little bit transsinusal, almost transsinusal, because it was tricorticalized, but they were well distributed. The patient was happy. And in the same day, following our protocol, or the all-on-4 protocol, we went through this, and this patient had a lovely Christmas. And at mandible, and I don't know, we are getting through the time, but in mandible, I always like to highlight one thing it's most important for me, which is the incision and full thickness flap, because it's very important to identify and expose the mental foramen. Okay, don't be afraid to identify, don't be afraid to expose the mental foramen. For those of you who didn't make such a big flap, try it, because it's very hard to damage this. It's a very hard fiber. So the best thing to identify is to go through a deep flap, a full thickness flap. After that, again, you can mark easily the place where your mental foramen is. So after you mark, you can work from there, anterior from that area, with all the safeness. Again, you perform the bone reduction. Okay, this is an example. It wasn't that patient. This is just the protocol of the mandible that I didn't want to leave you only with the Maxile protocol. So you go through the bone reduction. You have your mandible now clean and ready to do the surgery. Look at the shelf again. Okay. Then you place the multiplex insertion splint, and after that you can see here the mark. Okay, the mark that we did with the pencil, and you are working right over you. As you know, it comes out on buccal side, so it's very safe to work in there. and you prepare the anterior side also. Okay, sometimes people get trouble with this guide because you are working and the head of your handpiece touches there. So the best thing is take out the guide, put a parallel pin here, and then you can work in the same direction as your pin. After that, you place the multiplus, once again, the 30 degrees on the posterior implants and the straight ones of the anterior implants, and you place the titanium abutments, and you go for your provisional capture, prosthesis capture. And in this case, it was the technique that I was talking about, which is more conventional. I guess there is a lot of people that use this technique. When I started, I used this one, and it's a very good technique also because it allows you to protect all your surgical field, the stitches that you gave, the flap that you did. It protects all. Just place a dental dam. You go to the inferior prosthesis and you have the holes. This bar helps a lot. For those of you like prosthesis, you know that when making drills in a mandible, in the lower prosthesis, it probably will break when you do too much strength. So this bar helps that. After you put the prosthesis, you place fresh acrylic under the prosthesis. You wait until it dries, and after that you remove the prosthesis. You put again the reinforce the bar that helps to give strength to the prosthesis, and the dental technician does this work again. So regarding some tips, and nowadays there are several methods that we can use to get us better results, achieve better results. Personally, I only use these kind of options at our courses for didactic reasons, because nowadays I would say like 9 in 12 in 10 surgeries, I don't perform any kind of graft or any kind of uh, membranes with plasma. I perform it plainly. We put the implants, we open, we close, and the results are good also. But you have several things when you are performing the bone reduction with the osteotomy that I show you. You can pick the bone and you can mill with this bone grinder, manual bone grinder, and it goes like this. You can fill the sockets. It's a fantastic way of filling. You can put the membranes. Okay, everything that you can use after this surgery. As you know, this is a complex surgery. Even though we have the protocol nowadays, I can say that I perform this kind of surgery, I don't know, in about 1 hour, 40 minutes. If it's a dentalist person, if I don't have to document the case, or I can go even faster. But at the end of the day, if you have to perform this, you will be a little bit tired. So have a good colleague with you, or have a good staff trained to perform and to help you with this. Another trick is this particulate autogenous dentin with this lovely machine. It's called Cometa Bio. When you can you can took one of the teeth from the patient, and after you clean it, it doesn't have to be treated or endodontic. It has to be almost healthy teeth. So you go into this machine and you grind it, and you have this particulate autogenous bone dentin, sorry, which is very good for the socket preservation too. So we went to the surgery. We look at the main aspects of the surgery. We are reaching the end of the presentation, and we have to look at this big important thing, which is the way and the shape and the looks of our prosthetic provisional prosthesis. Sorry. So our prosthesis must be convex and ovoid, and she has to slightly press the gingiva. The patient won't feel anything because you performed the surgery 1 hour ago, so it's way better than placing the provisional prosthesis after 2 days or 3 days or after 8 hours. So the patient is still anesthesia. It has still anesthesia, so it's easier to fit the prosthesis, but he has to slightly press the gingiva. It has to be slightly polished. One of the biggest mistakes that I'm seeing every time that I go to some place without my technician or when I see other surgeries, it's a common mistake that is made by inexperienced technicians. They try to mimetize these areas around the abutment areas, and that can't happen. These areas, especially over here, they have to be flat. They have to be the most flat possible to look to make our tissues look like this. They have to be sometimes they have these marks of the pressing. The gingiva is getting too pressed, and the prosthesis it's convex, and that's the way we want to look. The immediate loading, when you go and you perform the immediate loading, you have to have at least 10 to 12 teeth with a maximum 1 teeth in cantilever, like here. Okay, don't go beyond that. And I only go with 1 teeth because the torque was very good. The polygon that we made was the implants were very well distributed. Then I can go with 1 teeth. Sometimes we have to short the distance, the AP spread, we have to short the distance, and sometimes people go without cantilever, even if the implant is on the fifth, okay, on the second premolar. I don't put any teeth. It depends on the AP spread. It depends on the distance that we have. And sometimes, almost what concerns in cost, sometimes the prosthesis of the patient can be used. I don't like it, okay, because with my provisional ones, I save a lot of work in the process of the permanent ones. Okay, we already changed the aesthetics, we already changed the function. I know now if I like uh, my plan, my speakers, where my incision is. And sometimes when we are dealing with the whole prosthesis of the patient, even if it's a recent in good conditions, we have to go and we have to use that kind of parameters. So after all, the message that I want to take from this webinar is try to understand the paradigm shift. It's the way we see things differently. Don't forget to plan well your case. And of course, you have to pay attention once again to the transition line. And then just follow the protocol. It's very important when you are surrounded by people who speak the same surgical language, the all-on-4. If you have colleagues, if you have people that you can speak with and they have the same philosophy as you, it's the communication is easier, the troubles happens, and then you can solve them. It's way easier when you speak with people that don't agree at all with that philosophy, even though if they are correct in their own way and they do things properly too. And of course, it's very important when you have a good team and you build yourself a team. Please build yourself a team too. These are the people that you need of. These are the people where you trust them in the clinic, in the office, during the surgeries. There are a lot of stress, and it's very good when people are always in the same mental philosophy. Surround yourself too by great people, as Marcio here. Right before the pandemics, we performed a surgery. I was telling him yesterday that we tried a very good Porto wine, and we didn't capture that moment. We only captured the moments that we are working, and of course, surround yourself too by good companies. No matter what company it is, as long as it gives you good support, it helps you when you need. And in my case, this is the one that helps me a lot. They provide me everything that I want, and it's very good when you work like that. This is our course that was programmed to be in June this year, was postponed as all the courses, but hopefully next year bring us a lot of good news. So thank you all for being here.
So yeah, Vitor Hugo, my friend, what can I say? It's was really a nice presentation. Very didactic. I told you yesterday during our meeting. Um, we went through the presentation. I really like it very much as a clinician. To see you really show the clinical aspects of the technique. You show your expertise with the all-on-4 technique. We call it a total rehabilitation over 4 implant in patients with posterior sector atrophic jaw, because in fact, in theory or in practice, we cannot use the term all-on-4. This is a trademark name now, so that's why we cannot use it. But we show your expertise on the all-on-4 technique, and thank you very much for the nice presentation. As the Dr. Vitor Hugo just showing, unfortunately, we were caught by the COVID-19 crisis this year. We were supposed to give a course at his clinic in June of 2020. We had to cancel it, but the good news is that we already rescheduled the course. The course will take place in September 2021. You will receive, we are finishing our international course catalog, and there are going to be very nice courses in 2021, and one of them will be the course at Dr. Vitor Hugo's clinic. As he said, Porto is a very beautiful city, so we're already looking forward for participants in this course. We have some questions. First of all, in the very beginning, we have from Dr. Sara Isabel Macedo Ribeiro. She said, "Great master, Vitor Hugo." She was sending you hello in the beginning of the presentation. Also, Zajad sent also the hello at the beginning of the presentation. So just to inform you this. A question: why do you prescribe antibiotics 3 days prior to the surgery? Are there any benefits of giving it? Are there increased chance of antibiotic resistance? So what can you say to us?
Actually, I didn't, I never had any kind of related resistance with antibiotic. Since the beginning, I give the patients 3 days prior. Sometimes I give them 5 days prior, depending on the periodontal disease they have, regarding the health conditions they have. As you remember, there was one person that has a lot of tartar, a really bad condition. So in the day of the surgery, I remove everything. So I don't do cleaning before the surgery. So in that day, I remove everything. And as we are dealing with a total cleaning of the bone, uh, the fact of the patient resisting had some resistance to the antibiotic, for me doesn't make much sense, because the protocol that I use, it's very workable. You know, you give the patient the antibiotic. I only give him at the day of the surgery the corticosteroid. Okay, I gave him the corticosteroid only in the day of the surgery, and then 3 days after he continues to perform that.
Okay, thank you very much. Just Dr. Leon, please send us a feedback if you have any more question regarding this topic, please. Um, then Joseph Mohammed, our colleague, says thank you for sharing your knowledge and experience. May I know what is the minimum diameter of the title implant used in the mandible for the all-on-4 cases? So the minimum diameter that you use, Vitor.
The minimum diameter that I feel comfortable using it is 375. I don't go lower than 375. But one thing that's very important, and thank you for thank you to the colleague that made that question, is that sometimes when you are looking at the CBCT, you look at the ridge of the bone, the crest of the bone, and you're gonna measure, and it has 3 millimeters. Don't forget to reduce it. When you start to reducing, to make the bone reduction, you are gaining millimeters in width, you know, the diameter. So when you start to reducing, the same thing for the upper jaw, when you start to reducing, sometimes the ridge goes from a very thinner ridge to a larger one, and then you have the shelf to put easily a 375 at least.
Okay, thank you very much. Dr. Sara also sent you congratulations for the lecture. If title implants went slightly intrasinus, what precautions should we take?
As long as they got higher torque, you don't have to have any special care, because they work as a sealment. They are going to seal whatever you open it. Okay, and I'm talking about a transinus situation. Okay, not when you go almost straight up and you open a huge a huge hole in the sinus. No, but when you go through cortical bone and you go, you really can feel with your implant that you are going through hard bone, okay, to the cortical bone, and at the anterior wall of the sinus, you really feel that cortical bone. So you can go slowly, okay, and sometimes if you feel, or if you see at the X-ray, the final X-ray, that you were transinus, or even went through a little bit of the sinus, don't worry at all. Don't worry at all.
Thank you very much. I think it was very clear. The colleague Sajad Hazani sent thank you also for the presentation. Question for colleague Matthias Ponrak. Do you ever use all-on-6 or only the all-on-4 technique?
That's a very good question. You know, when we have a very good bone, a very height bone, there's no problem at all to use the protocol with 6 implants. Okay, if you have a good height, you can go for 6 straight implants. Usually I never go for what I like to call a all-on-4 plus, which is the conventional with the tilted ones, and after that the straight ones. I never go that. If I have to perform a case with very good bone, the density of the bone is very important. It's probably most important, the density, then its quality, then is height or width. If it's too straight but it has a good density, you can go through him. So to be honest, this is such a comfortable treatment. And Marcio, you already performed surgeries. We already performed surgeries together, and the way as everything flows, and the way that we get high torques. And there is one thing that I always like to say, and people, if you remember that slide that you have 10 implants and then you add all on 4, one of the big questions about all-on-4 is always when people say, come on, if I lose one, what happens? If you lose one implant, you have a lot of bone usually to place another one. But if you have 6 or 10 implants, and if you lose another one, you only have this space. So you have to graft it. You have to try to understand if it's needed or not. Honestly, I feel very comfortable. Sometimes I use it, okay, but I have to have a very good bone, and I have to make sure that I gonna deliver my patient that day the fixed teeth.
Thank you very much. Dr. Andrew Macaranazza, just saying thank you, a very nice presentation. Thank you for sharing. Also the colleague, Dr. Farid. Hello, Farid. Thank you for your informative lecture. Would you please tell about the kind of occlusion you give to the patients?
Great question. The occlusion that I give in the day of the surgery, it's only between canines, okay? At from the canines backwards, it's not a balanced occlusion. The teeth are not occlusion. You have to pass the paper, the bite paper, the registration bite paper. You have to make him bite that, and you have to pass in usually a 40 micra, with 40 micro diameter. They chew, they bite that, and after that you have to pass, and it has to be flawless, but every patient in that first appointment where I explain all the treatment, I tell them that it's very common that they are excited at the day of the surgery. They are very very pleased for having the teeth, but 1 week after, they come to the office and say, look, this is all very good, but I can bite over there, back there. They easily forget those kind of informations, and therefore that's why I give them all this information in a paper. The patient at the first day, he gets a paper with all this information, the number of the teeth, the occlusion that he will get, and for 3 months he will only have occlusion in the frontal part between canines, and that's for the protection of the occlusion forces in the distal implants. I don't know if I was clear enough.
Yeah, everything fine, I believe. If there is any other point, Farid, let us know. Yurai, hello, Yurai, my friend. Do you give corticosteroids always? And what about when you use PRF?
I give more corticosteroids than I use PRF. So my protocol, or the protocol that I try to share or to teach for those who are starting, is to give a good medication protocol to start up with. That protocol doesn't change it from patient by patient unless you need it, because on long terms you will have your follow-ups of that cases. I don't give corticosteroids to everybody, okay? As I said, the workflow here is so fast. The things are happening so well planned, and um, as I said, Marcy, you were here. You said you see we made a very difficult surgery in about, it was a complex case. We did it a huge atrophic jaw, if you remember, and we did it about in 35 minutes or so. The fast you open the flap, the fast you put the implants, the fast you close everything. Sometimes I only give antibiotics to the patient, maybe a painkiller to do. But I have a strictly protocol of eyes, of post-surgery cares. But of course, I don't give corticoids and PRF. I don't use them so often. Okay, I know that the medication part, the history from the patient, the collecting the data, we could talk almost a whole new webinar about that, the vitamin D, the biphosphonates, the controversial things that are facing every day. But I try to resume the best way possible and focus mainly on the surgical part. But it's a great question too. But my advice again is you start with antibiotic, and of course if the patient can use it, corticosteroids and a painkiller, an anti-inflammatory maybe. You don't need a big medication protocol.
Thank you very much. Yurai, just give a feedback to us if the question is answered. Joseph Mohammed, thank you for the answer. And he has another one. Do you use surgical guide?
Surgical guide, I don't know if he's talking about the guided surgery.
Probably here, yes. Probably here, yes.
No, I usually don't do it, don't use it. I feel way much more comfortable doing what I call freehand, okay? Because it's such a dynamic surgery. When you open, when you make a full thickness flap, you sometimes you make it until the basis of the nose, okay, the nasal fossa. You work until the piriform zone. So sometimes you open that so much and you see 360 degrees of the bone. You have to work it dynamically, and sometimes for me it's my comfort zone. I work mostly 90% or 95% of the times with freehand surgery. The guide, the all-on-4 guide, or the insertion splint, it's very helpful at the beginning. It's very helpful, and it's almost what I call it a guide. For me, it's a guided surgery. That okay, and I don't do guided surgery, the conventional guided surgery, because I don't. My learning curve at that treatment, it's going very slowly. Every time that sometimes I want to perform a surgery like that, I have a colleague. We work together. I learned from him, but I let him take the comments.
Thank you very much. One, Johan Arif, say very nice knowledge sharing. Just wondering, did the type of bone give an effect to your planning in insertion of the all-on-4 technique? Most of perio patients will have low density bone. Correct if I'm wrong. Nice session.
Okay, let me go through parts. I understand the second part, and I don't totally agree that the periodontal cases or patients have the low density. You mustn't forget that we are all working usually, or 99% of the times we are working below, let's say in the mandible, we are working below the real dental, where the real periodontal problem is. We have to cut all that, all those sockets. We clean them. We have a very good curettage. We curate everything. We pass the drill, so the bone it's getting better by the time we are reducing it. Okay. um, so I don't feel, for my experience, that the higher the periodontal disease is, the lower density the bone has. I don't feel it like that. But I didn't understand, Marcio, the first part of the question.
The first part of the question was, if you was just seeing the other little below the question, sorry. Did the type of bone, do you believe that did the type of bone give an effect on your planning in insertion of the implants on the all-on-4? Do you make different plannings for different kinds of bones?
Um, Actually, I don't, because it's a technique where we are always aiming and searching for the cortical bone. We want to bicorticalize the implants. Okay. Uh, the palatal approach, and the all-on-4 shelf from Olatin Jensen, the palatal approach. There are several ways of going, of passing by the soft bone or the condition of the bone. For instance, in the palatal approach, the distal implants, you go almost through the palate. Okay, they have so much threads exposed, it's unbelievable. Sometimes you have a 15 millimeter implant and you have like 10 millimeters of threads exposed in the palatal approach, because it's all in the corticalization, okay, of the implant. So that's usually don't bother me.
Perfect. Thank you very much. Dr. Nazimi, thank you for the wonderful presentation. If the final torque is not good on the upper jaw, do you increase the size of the implant or allow for the osseointegration first, meaning that you can load it immediately? Thank you.
Thank you for your question. If the torque isn't good enough, if it isn't very a high torque, it depends. Are we talking about the 4 implants? High torque, you couldn't achieve high torque in 4 implants on the all-on-4 technique. That seems almost impossible. Sometimes happens. Sometimes you are dealing with a very complex, a very difficult case, a very trophic jaw. The anterior wall of the sinus is way too anterior, and sometimes you have to go but almost, if you have remember those limit, those anatomic limits, those millimeters that you have to have in the upper jaw, for instance, the 10 millimeters. If you have 10 millimeters in the front, you have to, it's a learning curve. Don't forget that. You have to under prepare the bone. Okay. The conventional way of placing implants, everyone knows, it's well refrigerated, not to overheat the bone. So usually people are trying to go to the exact mark of 10 millimeters or 50 millimeters, and you go through with your drill several times. In the all-on-4 technique, most of the times I only pass one time the drill. I go with my pilot, okay, I go with the 2.5 drill until 50 millimeters, and I go like this. This is exactly the speed that I go. I enter and I get out. So that's not much transformation for the bone and the implant, the threads of the implant, the anatomy, the fact that, for instance, the RSX, it's
it's the best implant to do this. It is a conical implant. It has aggressive threads, so you can work with it. But of course, if you are trying to make the technique, if you put your implants and if you reach only 20 newtons, for instance, in all of them, if you have a good bone, you should give a try and go with the bigger ones, not working anymore with the drills, only with the implant. But if you don't have much space left, you should leave it that way. Maybe leave the osseointegration process happens.
Thank you very much. In order for the multiplus abutment to sit on the title implant, what device do you use to remove the bone around the implant?
Oh, we used what I call the bone mill. I don't know, Marcio, are we sharing my screen?
You are still sharing your screen, yes.
Okay, perfect. I always is in the upper part.
Just while you find it, I'm just saying, like Atapan, just thank you for the nice presentation. Also Adiba and Farid. So thank you all for the
Marcio,
participation.
I'm not answering to those congratulations, but of course I'm the one who thank you for the kind words, and I hope that you really enjoyed the presentation, and I'm glad to see that people enjoyed it. Here it is, Marcio. I'm sorry for the
No
colleague
problem.
that has it is here. It has in both places. Sometimes when we are placing the implant, there's some remnant bone that doesn't allow the multiplus to fit. I guess this was the question that the colleague did, right?
Yes.
So we use the what it's called the bone profiler, okay? We together with the bone profiler guide. I have some awesome pictures of this procedure. I even have a video, but you must understand that this is a webinar. I had to make a resumed all the information I could, because in our course, for instance, we speak one day from morning until night almost, and we go through each step of the treatment, each topic, and I have videos of each treatment. For instance, when we are performing the surgeries in our courses, even if I don't need to use the bone profiler, I use it to the colleagues can see how it works. And here it is. It's a bone profiler. So it's a guide that we put in the head of the implant, and then we have like how do we call Trefina, Marcio? It's a burr that removes. You can go
The
without
Trifine.
problem.
The
Trefine, yeah,
Trifine.
it's almost like the same way a Trefine it's used. So I used it, and it was here. Sorry, I couldn't. I didn't read that.
Okay. Another question. Oh, sorry. Now I. Okay. Yeah, you already talked. Maybe just to briefly talk about it again. Do you perform any sinus lift or just place titled implants?
Always title.
Always title implants.
Title
Good.
implants.
Do we place here the what diet the patient can eat after the surgery?
So the diet that I advise the patient, the diet that goes on that chart, on that paper that he brings home. So it starts for very soft and cold food. Okay, first 2 days, 48 hours after the surgery, I don't want anything hot. I don't want any heat in the mouth. Okay, so only cold food, yogurts, jelly, ice cream, only good things too. But they can eat like that for the 2 days and make the most ice treatment they can. They put ice in their mouth. I always tell them to use the bags of peas that they have in the freezer, or a can of beer, or a can of soda, whatever they can push and do ice. It's a better thing. The diet, first 2 days softs, after that they have to go and make a graduate diet. Usually after 4 weeks they are biting. So after 1 month they can easily bite whatever they want, as long as that diet process has been respected. So when I say them to start, usually there is one sentence that I use. I think that resumes everything. Let me say, if I can say this in English. I usually say to my patient that they only can eat what they can smash with a fork. If they can smash a potato, a baked potato, they can eat it. No one can smash a steak with a fork. Okay, so if you can smash anything with a fork, you can eat it. The rice, you can eat it. The pasta, something that's not very hard to bite.
That's okay. That's nice. There is 2 more questions, and the first one is: do we place the position of the implant based on the classification of implant over denture, A, B, C, D, or E?
No. The placement of the implants after you go and see the CBCT, if you have the correct measurements, if you have the height, after you read the CBCT, after you study the case, usually, and we are in perfectly good condition here, if you are seeing this slide, and this question couldn't be better for this slide also. These laser marks, the laser marks on the guide, are between 7 millimeters. Okay, so 7 millimeters each line, each laser mark. So this is the middle line, and you know that the middle line because you already studied and saw the CBCT, and you know where was the middle line. So you marked you put the guide, and after that you have 7, 14, 28 millimeters, and by to place the tilted implant, you always go through the 28. So in 90% of the cases, it's incredible how the 28 laser mark, which is this one, 7, 14, 21, 28, sorry, which is this one, the implant goes here, and you can go through the 30 degrees, in which case, in this case, the which is a guide from other company. If you go crossing these lines, this point and this one, you have the 30 degrees mark. And it's incredible because in maxilla, the times of the time of number that you have to enter at 28, it's fantastic. And in the mandible, it's the 21. I don't know if I have it here in the mandible, the place is 21 to put the mandible, which is in almost 100% of the cases where the mental foramen exit of the nerve is marked at 21 millimeters from the middle line. Okay, let me see if I have here. Look at this mark. I was talking about it. 7, 14, 21, and here it is. You can see it's incredible. Almost 20, almost 10 on 10 surgeries goes like this. So you don't go with any classification of any treatment. It's like the classification of the rehabilitation. You can't go and perform a null 4 or a total rehabilitation over 4 implants with this technique, and you can put a FP1 prosthesis. You have to go with the FP3, which is this one. Okay, so you to perform this exactly treatment, don't forget what I said, follow the protocol. The protocol is from A to Z, and that's usually in the courses we go from A to Z. We search every kind of aspect, and this is what you put in this protocol. It's 21 millimeters on the lower jaw, 28 millimeters on the upper jaw, the entrance of the implant, and the anterior ones are always at 7 millimeters. Okay, so this is the correct position, and that's the position that I respect.
Perfect. Yeah, only 3 more questions. One more question, but before this, just once again, the thanks from the friend Yuri, also from Johan, Vladimir, Selfola. So everybody, thank you for your lecture. The last question, of course, is a polemic one. Would it not affect the fixture implant if the title 30 degree, 45 degrees? So it will be an influence on the masticatory forces. The title implant will give an influence on the masticatory force. I believe this is, and to finish the all on 4 lecture, is always the most polemic point about the title implant. So yeah.
If it influences the
masticatory forces, if the title implants influences masticatory forces.
Personally, I don't think so, because we can't forget it's this treatment when it's done and when it's finished, and that's only when you put the final restoration, okay, the titanium milled bar over the 4 implants, and it's correct and perfectly fitting, and the implants, the multiplants are straight, so the tilted implants have the perfect degrees. It works as one structure. So the concept of cross arc stabilization always goes with the same force. So the masticatory occlusion as doesn't affect in other way that affects the anterior. So it is all it is everything the same structure, and that is the concept of cross arc stabilization.
Yeah, my friend Vitor Hugo, I believe we have a so successful session. We have the Q&A session, so a very nice sharing experiences, sharing knowledge with the colleagues all around the globe. We had around 180 participants during the session, which was really very nice. So in name of BEGO Implant Systems, thank you very much, my friend, for your participation.
And thank you all. Let me say just, Marcio, I'm sorry.
No problem.
Let me show my email that's on the first slide. If anyone of you wants to share something or ask something more particularly, please be at will, and if I can answer, I'll be glad to. And thank you all once again for your presence and for your questions too.
We have one more. It's a friend from it's our distributor from the United Emirates, Virendra Shukla. Now it's too nice to have you here. He's sending also congratulations, Vitor, and yeah, he's a so sympathetic guy. So Shukla, hope that you are in best health there in the Emirates. So once again, just for the colleagues that are there, so next year we for the ones that will be interesting to know the nice city of Porto and the very beautiful clinic of Dr. Vitor Hugo Familiar, already can start to plan the calendar for September 2021. So Vitor is just going to share his email with us.
Okay, it's down here, and please be at will if you want to take my email and ask some questions. I know that from my experience, sometimes we want to have a doubt, or we want to make a question, and sometimes we don't feel comfortable of doing it because it can be a particular case or a case we are going through. Please be aware, and I'll be happy to help you if I can.
For sure you can. As the moderator of the session, there comes also our great colleague, Mr. Ralph Lexich. He's our colleague from the international sales, saying that was a great lecture and many greetings to you, Vitor. So thank you, Ralph, for being together with us, for all the support, also for the divulgation of this course was as all the colleagues from the international sales department and the national sales department also. As a moderator of the session, I'm going to finish it, and looking forward to see you all in our next online seminar. Thank you. Have a nice day and stay healthy.